All right, we are going to get started. So, good afternoon and welcome to today's webinar, which is The Road to Recovery, the Continuum of Care for Individuals with Brain Injuries. Thank you for joining us. My name is Rachel Ishak, and I'm a Community Outreach Specialist here at the Brain Injury Alliance of New Jersey. The Alliance is a nonprofit organization with a mission to provide education, awareness, prevention strategies, advocacy, and support for those who have been affected by brain injury. So I want to announce that we have some upcoming webinars for the fall. We're going to take a bit of time off for the summer, and then we're going to pick back up in September with our webinar on brain aneurysms, and then we have one in October on post-COVID. So you can check out our website for more information as those details are coming out. Just a few housekeeping notes before we begin the presentation. The attendees' microphones have been muted, so if you have any questions during today's webinar, please put them in the Q&A box, and we will get to as many questions as possible at the end of the presentation. The webinar is being recorded, and it will be available for viewing afterwards on the BIANJ website. At the end of the webinar, a link for a post-webinar survey will be placed in the chat. We value your feedback, so you are encouraged to complete the survey, and you must complete the survey in order to receive a certificate of attendance. So once you complete that survey, you will automatically receive that certificate of attendance via email. So our presenters for today's webinar are Kathleen Law and Kristen McLeod-Way. Kathleen Law is the Senior Director of Bancroft NeuroRehab's Central Jersey programs, where she oversees outpatient, home, and community neurorehabilitation services for the organization's Brick and Plainsboro locations. Law earned her undergraduate degree from Rutgers University, and she is a certified brain injury specialist trainer and a member of the Brain Injury Alliance of New Jersey. Law is actively involved in planning Bancroft NeuroRehab programs and activities. We also have Kristen McLeod-Way, who oversees the case managers and outpatient day services in Bancroft NeuroRehab South Jersey programs. Kristen came to Bancroft in 2006 as a case manager and has had experience in clinical management, finance, and senior case management. Kristen is actively involved in committees and work groups, and Kristen earned her undergraduate degree in psychology from Westchester University. So I am pleased to welcome Kathleen and Kristen.
Hi, everyone. Thank you so much, Rachel. And thank you to the Brain Injury Alliance of New Jersey. And thank you to all of you for taking the time today to learn a little bit more about brain injury rehabilitation. Kristen and I are very excited to be here to talk about a continuum of care for individuals who sustained a traumatic brain injury. Kristen and I do not have anything to disclose today. So let's start out with reviewing the learning objectives for this webinar. Following this session, you should be able to identify levels of care and the continuum of care, mainly for those individuals living in a residential setting. You should be able to understand the transdisciplinary team and approaches used in a residential setting. And finally, become a little bit more familiar with the variety of assessments that are used to help identify appropriate placements, as well as the transitions that come along the way. So a little bit about where Kristen and I work and have worked for 16 and 20 years, respectively. We and our teams are conveniently located throughout the state of New Jersey and are the experts in neurological rehabilitation. We strive at helping individuals reclaim their lives following a stroke, brain injury, or other neurological condition. Our comprehensive continuum, which is just one, of services includes residential rehabilitation, day treatment programs, neuropsychology assessment and treatment, as well as our outpatient therapies and vocational services. So as we do have outpatient services at Bancroft, outpatient services are typically primarily for OTPT and speech therapy and are offered for neurorehabilitation. Neuropsychological evaluations are used to help identify cognitive strengths and weaknesses as a result of an injury or condition. They also help to make a diagnosis. And so we also have ongoing psychotherapy to help with people to overcome their challenges and to adjust to the injury. The gold standard in rehabilitation is that 1-to-1 clinician to patient ratio, and most sessions vary from an hour in length. Specialization in Parkinson's specific therapies includes Big and Loud, as well as Parkinson's wellness recovery, power moves, speak out, and vital stim. And as at many organizations during COVID, telehealth services were offered, and we're still not sure of the future state of those services through telehealth. Day treatment programs offer 6 hours of daily structured programming consisting of social activities and recreation that help focus individuals and clients regain functional and vocational skills. We also can work on the daily living skills, which in turn enhance overall satisfaction and quality of life. Skills worked on during the day program may include communication and language skills, cognitive challenges with memory and executive functioning deficits. We also have robust vocational training, which at first may look like volunteer, working in small groups, and enhancing soft skills. We also look at behavior modification to address maladaptive behaviors. Community participation through recreation. We go to many sporting events, libraries, beach days, just to name a few. The main goal really is to stay active. So residential rehabilitation, a continuum of residential services for individuals with brain injuries, focuses on maximizing independence. As the needs and abilities of individuals serve change over time, they can transition or progress through a continuum to receive the level of support needed and appropriate. Sometimes individuals may need more intensive 24-hour supervision, and that can take place in a group home setting, or they may need periodic support, which can be achieved in an apartment and a less supportive environment. Typically, group homes and apartments provide contemporary living in neighborhoods, similar to how we all live. The individuals reside together, and they operate their homes very much like our families do. They meal plan together, complete household chores, and also plan their social outings. Success in this type of program looks very different for all individuals. For some, it can mean discharging home to their family after achieving and conquering all their activities of daily living, while others might receive some additional therapies that may be needed on an outpatient basis. And this can help build their strength and endurance, both physically and cognitively. And it could be for someone in a short term transitioning back to, but still needs accessibility and supervision while some at-home modifications are being made. For others, it can mean a longer stay while relearning how to navigate a home environment, relearning to ambulate independently, with or without assistance, and acclimating to participation back into community. So this can sometimes be longer term. So what does it take to run a program of this nature? Residential team members consist of professionals whose expertise varies from a direct support professional staff to a licensed clinical staff. All those individuals working together to improve the lives of the individual. Our direct support professional staff work alongside person served in the group home or apartment type setting. A manager might oversee the program and the direct care staff, as well as the individuals living in the program. We have leadership who can provide knowledge, as well as knowledge in licensing and accreditation, and look at the trends throughout the field. Healthcare needs are coordinated with the medical team, which include a nurse case manager. There's a healthcare coordinator as well as support staff to help transport and provide supervision during that time. A nurse provides education and training support to the team, and there's also case coordinators as well as clinicians to round out the team. So it really takes a village, and it really takes a lot of expertise in different levels of staff. So at this time, I'm going to turn it over to my colleague, Kristen.
Hi, thank you, Katie. I'm going to review the treatment approach. And as we mentioned before, there are many members of the transdisciplinary team. I'm going to review what a transdisciplinary team looks like as it relates to individuals' rehabilitation journey and moving through the continuum. Next slide. Thank you. So you can see the two quotes here from Carl. The one is transdisciplinary teams do not divide up the person based on discipline-specific areas of expertise. Also, Carl stated clinically, teams create a hierarchy of issues that need to be addressed and develop a plan to determine how each discipline contributes to that concern. This really means to me that once the individual has started their care, the team looks at the greatest need and addresses that need together. The need can vary based on the individual. During the rehab journey for an individual, the team looks at the ultimate goal, which could be helping that person get to the highest level of independence they can achieve. The transdisciplinary team will work with the individual, the family, and the funder to identify that greatest need, develop the goals, and help that individual meet that need. And then once the individual has met the need, there'll be a reassessment of the individual's skills to determine the next level that the individual might be able to obtain. You can see on this slide that the individual is in the center of the wheel. This represents a person-centered approach. Individual and families are needed to establish short and long-term goals. This could include what is needed to return home and what does the individual need to learn or reestablish for a safe discharge to the identified environment in the community. You can see that there's an admissions team included, which the admission team provides in-depth communication to the new person entering treatment to a residential program. Admissions team will coordinate screenings that involve record reviews and interviews with the person served, the family, and the transdisciplinary team. The treatment team then can consult to recommend a certain level of care. You'll also see that there are clinicians involved. They are really the clinical expertise to guide the treatment plans and enhance meaningful outcomes. These outcomes are typically looked at and are results from surveys to the funders and family and the individuals. And we're really looking at improving the quality of life and how they see that their life has improved. You'll see there's a nursing team. The individual will have a medical case manager that provides ease of admission and treatment access within the community for persons served and families. The nursing team will really be a peer-to-peer connection to external stakeholders such as a medical provider and case managers. Then there are case coordinators, and they are really connected to the families and funders. The case coordinators will organize the treatment plan. They see the overall picture of the treatment plan. They ensure that funding is present, and they solicit and provide input into treatment planning. And last but not least, there is the program. The program provides access to the continuum of care, transition planning, access to the community, and generalization of clinical services within the home environment. They will work with the rehabilitation team to discuss goal progress, barriers, challenges, and set short-term and long-term goals depending on the goals and skills of the individual. Now, on to day one. There are many different paths after an injury. This might be one path that we will review here. After acute care or when in need for residential placement, there is a referral made to a provider. The team reviews records for medical stability as well as appropriateness for community placement. The team will assure there is no exclusionary criteria such as active substance abuse and no PEG tubes. The team will consult with the admissions coordinator, who is really the subject matter expert to the team, and the liaison between the team, family, and funders until the day of admission. The team, like I had noted before, will provide an in-person screening. They will interview the person and do a skills review. The team will meet to review the screening notes, collaborate and ask questions, and determine if program is able to safely serve the individual, and also determine what level on the continuum that individual should start. Once the acceptance is received, the team will begin to develop a plan of care, obtain the funding needed for reimbursement for services. Planning meetings then start, and this takes a look at what the program can provide, what the individual needs to bring, guidelines on bedroom arrangements, and also when day one starts. There will be meetings to discuss any upcoming medical appointments, provider changes that may be needed based on the geographic areas. Goals of the individual, the family, and the funders are discussed and reinforced at these meetings. To note, if another facility is serving that individual, then the team collaborates with that current treatment team to ensure that there's carryover of functional goals and continuity of care. Now on to day one. The individual starts the program. They will move into the program. They can opt to have inventories done of their belongings to help keep track of their belongings. Program staff and caretakers can help the individual unpack, and the individual and family will get to know the team members and the home. Team members are also getting to know the individual. There again is more record review and screen by the team to help determine the initial level of support, which is how often the individual will need to be checked on, and again, review appropriateness of placement. The treatment team will complete assessments that are listed here on the slide, and these help determine the level of supervision needed. These assessments look at ambulation assistance needed, mobility, medical specialties needed, medical management, and special treatments like diabetes, seizure protocols, and support needed to manage medical appointments and follow-up care. When appropriate, a neuropsychological evaluation should be administered. This evaluation can provide an overview of the individual's strengths, needs, and barriers to rehabilitation. Going to look at the clinical team now. As you can see, we have an occupational therapies are listed, and they are licensed clinicians with a master's or doctorate degree. Occupational therapists evaluate and provide skilled therapy in the following areas: activities of daily living, instrumental activities of daily living, vision therapy, cognition, return to work, improving participation and independence in school, volunteer, leisure, home management tasks, medication management, financial management, and much more. Then you can see there are physical therapists who are also licensed clinicians. Physical therapy treatments after a traumatic brain injury have significant benefits, such as pain management with reduced need to narcotics, avoiding surgery due to contracture development, improved mobility and movement, fall prevention, improved balance, and exercise to improve and prevent many conditions associated with TBI, like weight management, stress levels, emotional regulation, attention, strength, endurance, balance, flexibility, and blood pressure regulation. Next, you'll see there is speech language pathologists, and they are also licensed clinicians with a master's degree and are certified by the American Speech and Hearing Association, ASHA. The speech therapist will evaluate and provide skilled intervention in the following areas: speech, language, social skills, cognition, and swallowing. There are also cognitive therapists, and they are clinicians with a degree in psychology, education, neuroscience, and/or other related fields who addresses underlying cognitive skills and functional challenges. The role of a cognitive therapist includes cognitive remediation programs, developing and implementing functional strategies, identifying barriers to progress and independence, and recommending environmental modification. They'll also address skills like memory, attention, problem solving, decision making, and safety awareness, organization and planning, social skills, and community reintegration. As we have talked before, a neuropsychologist is a licensed practitioner with a doctoral degree, generally in clinical psychology, and has completed a 2-year fellowship in neuropsychology. The role of neuropsychology is to conduct neuropsychological assessments to obtain a baseline of cognitive functioning and repeat testing to measure improvement or decline over time. They assist with treatment planning, identifying barriers to reaching rehab goals, provide patients and families with support and education regarding the injury, provide evidence-based psychotherapy to help patients cope with changes in cognition, emotions, and behaviors resulting from the injury. And they'll collaborate with the treatment team for a holistic approach to treatment. Last but not least, you'll see there is vocational rehab services. Vocational services in the neurorehabilitation setting is the process of enabling an individual with functional, physiological, and cognitive disabilities to overcome barriers that allow access to maintaining or returning to paid employment or other useful occupations, including volunteering. Vocational therapy is a person-centered approach, including identifying skills, interests, and personal goals, work hardening, which includes restoration of strength, endurance, and joint mobility, soft skill development, which includes communication, time management, hygiene, and grooming, and vocational services will also help with resume writing and interview skills. Here you can see this graphic really represents the residential continuum. It is not a linear continuum. It actually makes me think of the game as a kid that I played called Chutes and Ladders. Sometimes you get to move forward in that game, and sometimes you have to go backwards, and that really does happen in the residential continuum. Typically, upon admission, an individual will start their post-subacute rehab journey in a group home and attending a structured day program. As the individual progresses in their goals and is able to demonstrate increased independence in those goals and tasks, the individual will progress to the next level in the continuum, which is typically a supervised department setting. Once in the supervised department setting, there is less staffing needs, so the individual will need to be more independent in completing some tasks. As they become more independent in activities of daily living and instrumental activities of daily living, the individual can move to a supported apartment. Once at the supported apartment, there is an increased independence in accessing the community. The individual may move into the community, maybe with supports, maybe independently, and potentially just attend the day program. If the individual has a goal to become competitively employed or volunteer during their rehabilitation journey, the day program will work with vocational services and focus on vocational training by working with a transdisciplinary team to determine when volunteering is appropriate and when the individual may be ready to look for competitive employment. There are times that the individual may not need to attend a structured day program and can opt to just receive therapies until the clinicians and the individual is ready for complete discharge, which is, you can see that last step on the road to continuum. However, there are times that the individual's needs may become too great for the level of care they are residing at. This can include increased medical needs. At this time, the transdisciplinary team will assess and to determine what level is the best placement. And if more support is needed, the individual may need to move to a more supervised setting to meet their goals and meet their needs. Oftentimes that could be from a supervised apartment setting to a group home. Next slide. Here you can see the criteria for residential placement. Each setting has criteria that the individual needs to maintain to remain in and/or show that they are independent in each of the domains to move to the next level. You can see that our group home settings are our most dependent setting and will need supervision in almost all of the areas listed here. Next, you have the supervised apartment setting, and those individuals typically receive verbal prompts and use compensatory strategies to remain in that setting. Once those individuals become independent in those tasks, then they can move to the supported apartment, which those individuals are the most independent in the residential setting. All right, you're hired. So I'm going to pass this on to Katie.
Okay. So now you're all ready to be a part of the transdisciplinary team. So you're hired, and it's such good timing because we just had a bunch of records come in. And these records need to be reviewed, and we need your help. So we're going to review a few highlights from the records, and we're going to ask that you all consider if this person would be appropriate for a group home, a supervised apartment, or a supported apartment. And we're going to ask you to put your answers in the Q&A, and we'll see how well you all do. Okay, so first up, we have Maggie. She's a 40-year-old female who sustained a TBI over 2 years ago. She's impulsive, inattentive to verbal and written directions. She does not follow safety precautions and often does not respect the personal space of those around her. She is not receptive to following a structured schedule and, in fact, is often frustrated by any changes. She does not show good safety awareness. And so what setting do you think would be appropriate for Maggie? And Kristen's going to look at the Q&A to see what choices are popping up.
So we have a few so far.
Okay.
I'll just give a couple seconds for anybody else. All right. The majority, we have a couple that say group home. We have somebody with supported apartment.
Okay.
And somebody that.
Oh, go ahead.
No, I was just going to say another one that says supervised group home.
Okay. So we would place this person at a group home level, Kristen and I. I can see where supervised apartment, because supervised apartment has more supervision than a supported apartment, but still group home, and mainly because of the safety awareness and not showing safety awareness or safety precautions, as well as the impulsivity. A group home setting, as we mentioned, the staff are on site all the time, where some of the other settings, staff might leave to go check on other individuals. All right, so moving right along then. Next, we have Kevin. Kevin is a 55-year-old man who sustained a traumatic brain injury when he was 18 years old. Kevin is independent with his hygiene tasks. He oftentimes needs reminders to use his assistive devices, but does respond well to verbal prompts. He is pleasant to his peers and others in the community. He can at times miss social cues. He can talk a lot, as reported by his family. He is able to adjust to changes in his schedule and his routine. He is able to recognize unsafe situations and act accordingly. And he requires some support with his medical management and is independent with administering his medications. Which location do you think would be most appropriate for Kevin?
All right, we have a supervised apartment, a few supported apartment answers. Oh, looks like the majority is saying supported.
Whoa, ding, ding, ding. You are all correct. Great job. The individual can be supported in an apartment at this higher level. He is able to recognize safety concerns and can call staff for assistance if needed. So the ability to also wait for staff to come help is key. So that's great. Good job. All right, next we have Henry. This is the last one. Henry's 65 years old, and he sustained his brain injury when he was 31. Henry requires verbal prompts to start his hygiene tasks. Once prompted, he will take his shower. He needs some visual reminders to prepare a meal. There are times where he will refuse or decline to prepare meals, as well as completing other tasks such as laundry and maintaining his bedroom. However, it only happens a few times a month. Where would be the best placement for Henry?
All right, so we're starting to see supervised apartments. Some are saying supported apartments, some are saying group home. This
Okay.
one's a little bit trickier.
Yeah, this one can be a little tricky. I see that, Kristen. So we would have this person at a supervised apartment level. And I think mainly with the reminders for preparing a meal, that in a supervised setting, if an individual declines or is not able to, the staff are able to prepare that meal for Henry. So I think that would be the best, the supervised apartment would be the best setting in the least restrictive environment. So great job, everyone. Thank you for your participation. All right, so next we're going to talk about some success stories. We have a couple here for you, and this is just one. We're going to talk a little bit about Matt. Matt sustained his traumatic brain injury in 2011. He was snowboarding and had an accident. He was found 2 to 3 hours after the accident. So he had some hemorrhaging in his brain, multiple contusions, and he was in a coma for about 2.5 weeks. He had a short subacute stay. He has a very supportive family, so he was able to be discharged home. He did start out his rehab as an outpatient and as a day program participant. And in 2013, he was a day program participant. He then transitioned to a group home setting at Bancroft. And so Matt lived initially in a group home with 4 other peers. He was highly involved in home management activities, such as cleaning, laundry, meal planning, preparation. He participated in social and recreational activities with his peers. Many of his therapies took place in the home and now in his apartment. His therapist collaborated with all levels of staff and really maintained open lines of communication to adapt to the goals as he achieved them, so that we could be sure that he was moving along the continuum and continuing to increase his independence. So the transdisciplinary team really took place with this case study. He participated in all therapies. So first I'm going to talk about psychotherapy. Sessions really focused on his thoughts and emotions and behaviors as they related to his journey. During sessions, Matt worked on the acceptance of his new life since the TBI and identifying values and goals for his future, as well as the strategies that would be needed to cope with all those changes and his mood. So one thing about Matt is that he really enjoys writing and strongly values his independence. So you're going to kind of see that theme throughout this case study. He's able to utilize time independently and began initiating writing blogs as just a starting point to him enjoying writing. He participated in physical therapy as well, which really helped focus on the physical aspect of his journey, being able to ambulate safely and independent on all levels of surfaces, both indoors and outdoors. The grassy, uneven terrain, the curb cutouts, and using with an assistive device along the way. So Matt progressed from primarily using his wheelchair to now using a walker. So many trips were out in the community, trying to learn how to manage the environment and course correct from there. And occupational therapy really worked hand in hand with physical therapy, and they worked on the strengthening of his extremities, managing some spasticity, And really at the low level, learning how to reverse wheelchair brakes with the left hand instead of the right hand. Also working on transitioning and transferring from his wheelchair to other chairs, to his bed, to the commode, and also learning how to cook at the stove at the wheelchair level as well as at the standing level. The progress he's made has really been significant. Going from being able to use the stove and the oven at a wheelchair level, but also being able to use it at a standing level as well. Matt also enjoys physical exercise and activity, so it's really important for him to get out. And he also uses now a recumbent bicycle on the streets. So that was really some great progress on his end. During speech therapy, he really had to overcome challenges for speaking clearly and eating safely. So formal goals worked on his intelligibility, compensatory strategies used to slower his speech, and also exercises to help with swallowing. It was a concern that Matt would be at risk for choking, and it took Matt a lot of time and energy to come around to some of those strategies and to maintain them consistently. Once he was able to do that, he's independent with following any protocols he has for swallowing and eating, and knows what to do to help reduce the risks of aspiration. In cognitive therapy, they worked on putting it all together using mindfulness and really honing in on the compensatory strategies for memory and time management, as well as problem solving and decision making. Some of the compensatory strategies that Matt would utilize and still does on his Apple phone apps for note taking. He also had some, less tech savvy strategies using a binder with a detailed, structured schedule that was often color coded and broken down hour by hour. He'd also use phone alarms as reminders. And putting all those things together really helped him with his independence and being able to carry over any kind of home exercise program, things of that were kept within his schedule. So he was really able to maintain his life and carry over the skills. And in vocational services, the assessment and interest inventories really led Matt to believe and know that his vocational aspirations were to be a freelance writer. Matt wrote a book, and after he completed that book, he really realized that writing was his passion, and writing about his injury so that he could educate others out there about his story and how to impact and prevent others, providing education. He partnered internally at Bancroft and wrote small letters for the newsletter, small little articles, and also submitted some of those articles externally. He had a publication in New Jersey Micromedia, and recently was accepted to the New Jersey Traumatic Brain Injury Advisory Board, where he is using his passion to help others and being connected to the brain injury community. Okay, I'm going to pass it over to Kristen to talk about the next success story.
Thank you. So I'm going to review Shane's story. So I was able to speak with Shane recently, who was willing to share his rehabilitation journey. In December of 2018, at the age of 27, Shane suffered an anoxic brain injury from an overdose. While in the hospital, doctors told his family that he may never walk or speak and may need to remain in a hospital setting for the rest of his life. When he was stable enough, the hospital transferred Shane to an acute care where he was able to work with his physical therapy on transferring. When Shane was transferred to subacute, he told me he felt he wasn't reaching his full potential, but continued to work towards his goals. His goals included not needing to use the wheelchair and being able to do a push-up. He was admitted to Bancroft in February of 2020 in a supervised group home. He was able to utilize his transdisciplinary team that included occupational therapy, physical therapy, speech therapy, residential and day program, neuropsychology, nurse case management, and case coordination to move through the continuum. What I really got from talking with Shane was he was really able to push himself at every opportunity and really work hard to increase his independence. You can see he has quickly moved through the continuum from a group home in 2020 to a supervised apartment setting in 2021, and then ultimately the supported apartment in 2022. We are going to play a video where you're also going to see that Shane had the opportunity to participate in Taekwondo and earn his yellow belt. And I'm happy to say he does not, or he can do a push-up at this time, and you'll see that he does not need to utilize his wheelchair anymore.
Don't let anybody ever tell you can't or you won't do something. All you need is faith, hard work, and determination, and anything is possible.
It's always such a touching video. Pulls at my heartstrings every time. So I hope you are all able to see that impact in Shane's life as well. I know Kristen had noted earlier that it's not a linear path, and the chutes and ladder example is really a great one. Taking some steps forward and taking some steps backwards. The important thing is for people to continue to feel like they're moving forward, and that they're engaged in a meaningful community of their choice. So we hope that you all enjoyed the webinar, and we identified levels of care within a residential setting, and how well the transdisciplinary approach, especially in the success stories, shows that it really can make all the difference, and how the right assessments and interventions breed success. Thank you all so much for joining us. I know that we might have some questions and answers right now that we might want to go through.
Great. Yes, thank you both so much for that really informative presentation. And so now we're going to take a couple of questions from the Q&A. So if you have any questions, please put them in the Q&A chat now and we will review them. So we have one question come in that says, what funders will pay for residential rehab?
That's a great question, and a question we get a lot. There are many different types of funders that include state funding, which would be through different programs through the Medicaid, managed long-term supports and services. And then there's the developmental disability, or the Division of Developmental Disability, that will also do funding for services. Sometimes there is private pay, private insurances, commercial insurance that we talk about, workers' compensation, that will pay for some of these services.
Thank you very much. Another question is, you mentioned exclusionary criteria. Can you give some examples of more exclusionary criteria?
Another good question. So Kristen had mentioned PEG tubes. So any type of tube, feeding tube necessary that requires a higher skilled nursing component would be an exclusionary criteria, unless there was a funding source to pay for it. We did mention nurse case managers, however, they are not on staff 24/7. So if there's that higher skill medical need, that's where we'd either come up with something that we can manage safely and appropriately, or that would be an exclusionary criteria. Also, we mentioned substance use. active substance use. So really active, right? If someone's in remission and has gone through treatment, then they will be a good candidate, but maintaining their sobriety is a huge piece.
Thank you. Right. One other question came in. How do you ensure that the individual characteristics, so for example, culture, language, or religion of a person are accounted for during rehab? Good question.
Great question. Kristen, do you want to take a little bit of that?
Sure. So really, as we talked about in the transdisciplinary approach, the person and the family are part of that transdisciplinary team. So we are asking the person and the family, what are their cultural, we actually say cultural needs, right? We want to know how to make sure we're incorporating everybody's needs and addressing that, from religion to food to activities. So we really incorporate that, and we'll document that in the treatment plan to make sure that staff are really aware and are taking everything in their with their culture in account.
Mm-hmm. Yeah, most of the time we see religious needs. So taking to churches and places of worship of their choice can sometimes be difficult, especially if there's 5 individuals with 5 different churches. So we're able to, open that up to 1 week we might go to one church, the next week we might go to someone else's church. And so it's all very individualized, but like Kristen said, we're asking those questions and talking about it before they're admitted.
Great, thank you for that. Another question, what is the process like to get on the waiver services through Medicaid? I don't know if you guys have any information on that.
Oh boy, do I have information on that. I could do a whole nother webinar on that process. It is a big process. And for the first step is to applying for Medicaid and making sure that you would qualify for Medicaid. So Medicaid being, and I'll try not to take up all the time because I talk about this all the time, but Medicaid being an income-based funder source, you have to make sure you qualify for that. So you would want to, you could start on the New Jersey Families Care website and, go through that process. And then once you do, then you want to ask for managed long-term supports and services. So that's another aspect of that. And dependent on the age of the injury will depend on who funds, whether it's what I had said earlier, DDD or MLTSS. But there are a lot of resources out there. I don't have them on the top of my head, sorry. But online you can check out New Jersey Family Care. I think that's the first great place to start.
Great. And actually, I'll make a little plug. I think we have a webinar coming up later in the year on some of that, so kind of stay tuned. Okay, great. So maybe just a little bit about Bancroft. Do you serve, well, let me rephrase it. What ages do you guys serve? Is it just adults or do you serve pediatrics as well?
So in the brain injury program, we serve adults 18 and older. Bancroft does have a large pediatric adolescent school and programming. So I think the best place to start would be contacting our admissions department to see if you would meet the criteria for any of our programs. Because like I said, we do have children with neurological impairments in our school and in our residential programs there. So maybe we can include like admission contact number, Rachel, when we send out the slides.
Yeah, absolutely. You can note that. Okay, great. Next question we have is, when do you start discharge planning?
Day 1.
Yes.
Yeah, discharge planning is really important. So we want to establish if there is a designated discharge location. And if there is, then we would work that into the plan and have that in the team's mind so that when we're working through goals, we know what the end game is. If there's nothing identified early on, then that will come through as the person goes through the rehab process and their journey.
And as we discussed, it's a linear process, and also discharge setting may change based on the individual's need as well.
Thank you. Next question. What is the threshold for behaviors, and when would someone be considered for a behavioral or a medical group home environment?
Yeah, that's another good question. Individualized, but also if there's a behavior plan in place. So we talked about some behavior modification. And if the plan is getting to a point where it requires that one-to-one staffing to really monitor the plan and keep the person safe, then that's when we would start moving in that direction to consider that placement. As for medical, the same thing, kind of what we alluded to earlier, is when the scope of the needs exceed what we can do in a community group home. And when the medical skilled need might be a little bit more, where we would need more nursing oversight.
Great, thank you. Are there any sites near Mercer County that you guys have?
Yes, we are located just outside of Mercer County in Plainsboro. We have group homes in Mercer County, the Hopewell area. We are in Ewing Township, Middlesex County. We're in that county as well. We're over in Ocean County as well. So Camden County, Gloucester County, Ocean, Mercer, Middlesex, Monmouth.
Great.
Yeah,
all over. Awesome. Back to Medicaid. For Medicaid, does it have to be straight Medicaid, or is it the standard Medicaid with an HMO managed care?
So I'm only speaking for Bancroft for what we take, but it does have to have the HMO as well as what is called a TBI designation. So that has to be assessed to be determined. And then that's when you'd be able to access the TBI services with Bancroft, once that HMO and the TBI designation are received.
Do you think that's standard other places, or it's really dependent?
I mean, I would think it might be a little standard, just because, again, straight Medicaid would not typically pay for a residential day or a bed. So yeah, my best guess would be yes.
Yeah. Okay. Great. Thank you.
Don't hold me to that.
Yeah. No, just a question. How reliable do you find neuropsych evals?
I find them extremely valuable and accurate, right? Is that what the question was?
Yeah,
accurate?
reliable was the question.
Yeah, I mean, I find them extremely reliable. We use them for treatment planning, and we also rely on the updates. We rely on the updates to compare them to prior years, to make sure that we're staying in line with any cognitive changes that happen over time. As we all age, our brain changes. And so it's important, especially for somebody with a traumatic brain injury, to follow those changes over time.
There are also, and I hope I'm saying this right, but like a norm test, there's standardized testing that they use and have lots of research behind that testing to show their effectiveness, as well as how often they can be done, how soon they can be done, when they can be done. So we do really utilize them as our backbone for the treatment plan.
There's actually a question that came in that goes in hand with that, and asking how frequently you update your neuropsych evals. So I guess maybe how frequently can they be redone?
I've seen for newer injuries, every 1 to 3 years. For some older injuries, you might want to do maybe 3 to 5 years, but it really would depend on what the neuropsychologist recommended at the last eval. So again, I've seen newer injuries get one every year, just to, again, keep track of those changes.
Also, in a newer injury, it may not be appropriate to do right away as well. So the team really assesses that and determines, like, okay, and works with the neuropsychology department to say, okay, now we're ready for this neuropsych eval, because there may be some clearing time, and that can vary based upon the injury and the individual.
Great, thank you. All right, I think we have run out of questions. So if anybody else has any last questions, feel free to type those in the chat. We have just a couple more minutes, but in the meantime, I just want to thank Kristen and Kathleen for being here today and sharing all this great information. We really appreciate you taking the time out of your day to do so. And if anybody has a question that they think of later on and they would like to ask it, you could feel free to reach out to me and I will send your question along to Kathleen and Kristen and we can get you some information to answer that question. And I'll put my email in the chat. You can reach out to me. And then also in the chat is our post-eval survey. Please fill that out. We would love to hear from you what you thought about today's webinar. And if you are looking for a certificate of attendance, you need to complete that survey in order to receive that via email. So I don't think I see any more questions. So thank you everyone for attending and we hope to see you at the next webinar. And this concludes today's webinar.
Thanks, everyone. Bye.
Thanks.